Okay, thank you so much for those questions. We shall take more questions, but we can have Dr. Okuku, a senior medical oncologist at the Lung Institute. Dr. Okuku, you're welcome.
Thank you very much. Can we go to the next slide, please?
Let me just share again.
Next slide. So as they move the slide, maybe I should start by okay. Let me start with just a little background of how we approach diagnosis of lung cancer. So as Professor Bruce has already introduced issues of symptoms. Once you have those symptoms, you see a doctor, and once a doctor has noted the mass in the lung, they will take a tissue biopsy. And that tissue biopsy will be analyzed by the doctors. And this is what might come out of the tissue biopsy on histopathology. So histopathology is an analysis done by a specialist doctor called a pathologist. He looks at the tissue and tries to make out what type of lung cancer. Now, there are many types of lung cancer, and the commonest we see in Uganda is an adenocarcinoma. As you can see, that which I'm pointing towards there, that is the blue color there, 52%. Another patient may have what we refer to as squamous cell, and sometimes we may have other non-small cell. This NC stands for non-small cell lung cancer. That's about 11%. But you may also have people with large cell lung cancer. So this description is on histopathology. So when you look at it further, the non-small cell are the commonest. Majority are non-small cell. The small cell, what we see in smokers, people who smoke, get the lung cancer type called the small cell type. Next slide. Next slide, please. Okay, as they get to the next slide. So this is what we analyze, and then after that analysis, we then will move on to your treatment. But that is not all. We will now move to what we are referring to as biomarkers. As you're aware, there have been many changes, and diagnosis of cancer generally has improved, and we can now be able to see much more than what you see on the ordinary microscope. So the tissue that I've described here can be taken further, and we do a molecular diagnosis, or what we refer to as immunoprofiling of the tumor. So there are other markers that you may not see on the microscope, and immunoprofiling does help us to be able to bring out details about a particular tumor. So this slide, we would like to show you the commonest biomarkers in these tumors, the non-small cell lung cancer. And as you can see, the small cell squamous cell carcinoma has a lot of biomarkers, as you can see. The commonest here is the EGFR, which stands for epidermal growth factor receptor. That is the commonest biomarker in non-small cell. It also happens in adenocarcinomas, and as you can see, we have a significant portion of patients with adenocarcinoma of the lung expressing the EGFR. However, they also do express other markers. You can see the KRAS. These are all mutations that have been found in many of these patients with cancer of the lung. So when you have been diagnosed, this is a further analysis that is done on the tissue. Unfortunately, many of these tests are not easily available in country. Some of them are, and at UCI, we do have the capability to run these tests. The platform is available. I know that the lung study that we are running right now also has the capability to run many of these tests. Next slide. So those tests that I have described, these mutations, are a requirement. So we need to check your tumor. We need to check the patient's tumor for all these biomarkers that are listed here. However, it's not practical. As you can see, there are a myriad of biomarkers, and these are very expensive. So we tend to go by the commonest. As you have seen, EGFR is common, LK is common, KRAS is common. The other EGFR biomarkers that are also common. As you can see, the list is over here. EGFR other is 2%, KRAS is 25%. So going by this, we try to, because it's not practical to run all this, so we normally run 3 main ones. So a typical patient will have, number 1 will be the epidermal growth factor receptor mutation. As you can see, the very first one there. We will also have the KRAS mutation, the LK, and LK stands for anaplastic lymphoma kinase mutation. And then we usually also run the ROS1. These are quite common. They have targets in terms of drugs to target those. So most of those which we run have targets. So in other places, we would have mapped out our population already, and we would know by now what are the commonest mutations in our population. My clinical practice and experience tells me that EGFR is quite common. The lung cancer patients who receive who are close to 800, probably 50% of them will be expressing the EGFR, and that's how it is world over. Next slide. So those mutations are called driver mutations, and those are the ones that cause the cancer to grow. And so clinical application of that is that once you find the biomarker expressed in the tumor, then you need to target that biomarker using a target. And those drugs are targeted therapy drugs that are available. And these are some of the examples targeting particular mutations: epidermal growth factor receptor inhibitors. The commonest here is erlotinib. We have gefitinib, which was the first, these are first generation. We have osimertinib, which is a second generation drug. We have a lymphoma kinase inhibitor and ROS1. These 2 mutations are very similar. They're like brother and sister, and so the same drugs work for both of them. Crizotinib, alcatinib, and brigatinib, all these are available. We can easily get them for our patients. There are some very rare mutations or biomarkers for these particular inhibitors, like MET inhibitor. Crizotinib, again, is one of those drugs that we use for the anaplastic lymphoma kinase mutation, but it can also be employed in when we have MET mutations expressed in tumors. Some lung tumors also express a very similar mutation that is driver mutation that we see in breast cancer, that is the human epidermal receptor 2. The drug of choice here is trastuzumab, afatinib. These are all available in UCI. We do give trastuzumab free of charge to most of our patients. We have RET inhibitors, cabazitatinib. We have BRAF inhibitors. Next slide. We have MEK inhibitors. We have the NTRK1 inhibitors. We have the PIK3CA inhibitors, and the PDL1. These are checkpoint inhibitors. I will speak a little more about these, but some of the drugs we use here are atezolizumab and pembrolizumab, which is one of the commonest immunotherapies. So the PDL1 biomarker is one of those biomarkers that we do on lung cancers because it's expressed on some lung cancer tumors, and we do have druggable. This is a druggable driver mutation because we have drugs that are available to block that driver mutation. Next slide. In this slide, I want to show you FDA-approved targeted therapies. You need to have an eye of faith to be able to read through this, but it's a crowded slide, but it's just what I have already highlighted in my previous slide. Drugs like osimertinib, we have afatinib, erlotinib, and many others. Next slide. These are further mutations. Some of these have been approved and some of them are in the pipeline. They are yet to be approved by the biggest authority in terms of drug approval is the FDA, and many of these researchers will first get approval from the FDA before the drugs can therefore be distributed all over the world. Next slide. And this slide, I want to show you the different immunotherapies that are available for treatment of lung cancer and when they were approved. Atezolizumab in 2020, pembrolizumab 2016. There are others that were approved with combination with chemotherapy, like pembrolizumab and paclitaxel or nab-paclitaxel. This was 2018. Next slide. Right. Before I conclude, this is one of my last slides. I should hint a little bit about liquid biopsy. Sometimes we have very sick patients, elderly patients, where we cannot do tissue diagnosis. We can't take a tissue. And the liquid biopsy is one of those that we can employ on a variety of cancer biomarkers. And some of the biomarkers here that are picked up on the liquid biopsy include circulating DNA, abbreviated as ctDNA, the microRNA, and circulating tumor cells. So when you have a cancer going on in your body, what can happen is the cancer keeps breaking off and going into the blood circulation. And so doctors can utilize that, take up the blood sample. They can also take plasma, they can take urine and figure out what is going on. And in lung cancer, this is one thing we can apply. We can apply a liquid biopsy to help us make some, infer to what might be happening. So patients who are medically unfit, instead of going through a very difficult invasive biopsy, intrathoracic or percutaneous biopsy, a liquid biopsy is one that can actually be employed. We could also employ this as a response marker to see how you're responding to treatment. I think this should be my last slide. Thank you very much.